Hello, welcome all. Today I would be discussing about the retrograde PCI basics. So it is the start of the retrograde CTO PCI Academy, and I would be discussing all the techniques of the retrograde PCI along with the algorithm as well as the hardware used. So today I would be discussing in brief how to think where to start retrograde PCI. So as after once we are well versed in anti-grade CTO PCIs, then we should also think about going with the retrograde PCI. So it's a very age-old algorithm which shows that dual catheter angiography should be done, and when done, it shows a good integrate, clear proximal cap, and good distal target. Then, of course, we should go with the integrate strategies like wire escalation, ADR, and this is usually successful when the lesion length is less than 20 millimeter. But many times we don't succeed in this and we have to go retrograde. And for retrograde also, if the lesion length is more than 20 millimeter, good intervention of collateral, the proximal cap is not clear, uh, and we have a good retrograde collateral that we can serve, and we can cross it with the retrograde wire, then of course we should think about retrograde wire escalation. If it fails, then of course there are some dissection re-entry can also be tried. So first of all, we have to keep in mind there are various stages of learning of a CTO. In stage one, the young operator should go with the integrated wire escalation techniques, and he should go beyond that once he is well versed in integrated wire escalation by integrated dissection re-entries. And after reaching the stage two, we can go with the stage three and four. In stage three, uh, we should keep in mind the pace tolerance curve. That means we should increase our pace, and accordingly, that once we are well versed in integrated CTO technique, then we can go ahead with the retrograde PCI, because this requires a more better skill. And in stage three and four, we can in stage three retrograde PCI via septal collateral or bypass graft should be tried, and this ADR can be tried. And once we are well versed in retrograde PCI by septal collateral, then we can go with the epicardial collateral as well, because epicardial collateral are fragile and many times they are prone for spasm. So it's a bit difficult. So this is what a hybrid C2 approach for C2 intervention, and these are the level of complexity. So before starting any retrograde PCI, we should keep in mind that it requires a certain level of knowledge, skill, expertise, and the good number of integrated CTO PCIs to be done. And again, it is a different algorithm which suggests that we know when the JCTO score is less than 0.1, then of course primary integrate approach would be good, and guide wire manipulation time is usually 20 minutes. But there are some cases where we have to keep in mind that primary retrograde approach would be needed, and once integrate is failed, and this is a good choice to go retrograde. And if the good intervention collateral are available, and at least one variable is there, that is CTO length more than 20 millimeter, and it is a reattempt, or it has a CTO entry type with no stumps. That means if there is ambiguous cap, and or maybe it may be ostial in location or the failed CTO, then these are the things where we may even try to go with the primary retrograde approach. So these are few places where we should keep in mind that retrograde PCI would be better. So this is most talked about global CTO occlusion crossing algorithm. So in this, dual injection analysis is done of the coronary angiogram. If there is no praxical ambiguity, then we can go with this integrate wire escalation. If there is ambiguous cap, then if there is presence of side branch, then of course IVUS would help. And if our integrate approach is not succeeding, then of course a retrograde approach should be taken. And there are various points where we need to stop. So that should be in our mind once we are doing a CTO, and if it is duration goes more than 3 hours. If 3 to 3.5 times GFR, the dye contrast is used, or air karma more than 5 gray, unless the process is well advanced. So these are the procedure where we can stop, or we can stop at the investment stage. So this is the algorithm that should be kept in mind. And this is a very important article which suggests that what are the indication for the retrograde as a primary approach. So again, coming back to those things, that proximal cap ambiguity, where even IVAS cannot lead us to a breakthrough across the CDO. If there is a bifurcation in the distal cap, if it is very difficult to engage the CTO, it is having anomalous coronary artery, if it is a diffuse disease vessel, or the most important of above is flush aorto-ostial occlusion. So we would not get a point where we can try to negotiate the CTO. And of course, for secondary retrograde approach, it is the failure of the antegrade attempt. So this is the latest Euro intervention algorithm. We suggest that if we are not able to go with antegrade approach, then we can take bilateral injection that will show septal or epicardial collateral. And there we can use various technique like direct retrograde crossing or kissing wire technique or contemporary reverse cut or knuckle cut. So these are the main four techniques that are used once we are going retrograde. And I would discuss later one by one these approaches, how to approach these techniques in a retrograde manner. So this is retrograde techniques, that is kissing wire technique. The retrograde wire is put as a distal marker and where antegrade wire can be negotiated. In 10 to 20% of the case, even the retrograde wire can cross it, to the true to true lumen. And another technique is card, usually not done nowadays, but many times in this, it can be done in a calcified CTO. The wire knuckle can be made. So knuckle card is done in the calcified CTO. And the most commonly done is shown in D, that is reverse card, in which a balloon is dilated at the antegrade wire and the retrograde wire is negotiated, keeping that balloon as a marker. And thus dissection space created by the balloon will help the wire to come from lumen to subintima to lumen. So these are the main basic algorithm of how to go with the retrograde CTO, what are the indications, and what are the indications for the primary retrograde PCI. And in next session, I would be discussing in brief what are the few basics that have to be kept in mind before starting a retrograde PCI. Thank you.